Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum. This session is part of a trauma course based on WHO course, Basic Emergency Care. This session will focus on primary survey. The overall objectives of this basic emergency course trauma module to recognize key history findings suggestive of high-risk trauma, recognize physical exam findings suggestive of high-risk trauma, perform trauma primary survey, ABCDE approach, tailored for trauma patient, perform trauma secondary survey, head-to-toe trauma exam, recognize life-threatening injury, perform critical action for high-risk conditions. In order to master management of patient who are victim of trauma, you need to have certain skills, cervical spine immobilization and spine immobilization, and how to transfer patient and do log roll, plus airway maneuver like jaw thrust and airway suctioning, how to place oropharyngeal, nasopharyngeal airway, and if the patient is stable, how to put him in a recovery position. Also delivering oxygen and delivering ventilation by bag valve mask, and to do needle decompression for tension pneumothorax, three-way side dressing. These skills are gonna be, there will be a sheet with a link on these important skills. You need to check that you master them before you can deliver good and successful management of trauma. Generally, when we handle a patient with trauma, early priority for an injured person include the same we do for every person, ABCDE approach. We would like to make sure airway is patent and his breathing is adequate and efficient. And at the same time, we would like to control any obvious bleeding and treat shock as early as possible, and recognize that in trauma patient, we have to immobilize spine when this is indicated. Trauma can lead to life-threatening injuries. So our goal is in the initial assessment and primary survey to identify life-threatening injury and manage them appropriately. At the same time, patients with trauma are at risk of secondary injury. Most secondary injury are related to poor oxygenation and poor perfusion. So we would like to prevent secondary injury by managing oxygenation, perfusion, and at the same time, trauma can lead to devastating and severe pain, and we have to manage pain and to plan ongoing care and whether it's appropriate to manage this patient in the same facility or to transfer to another facility. General approach, the frame for approaching a patient with trauma is to go through three phases: primary survey, sample history, secondary survey. In the primary survey, we implement the ABCDE approach. Then we go to sample history. We'll discuss that in detail in the second session. And then we go to trauma secondary survey, in which we do complete head-to-toe examination to identify any injury not identified during the primary survey. During assessment, if life-threatening problems are identified, stop and manage and go back to primary survey. Assess, manage, monitoring. During the monitoring phase, if you discover any problem, go back and assess and manage. ABCDE approach is a dynamic process. It is repeated multiple times. Patient with trauma can present with severe injury and that can be recognized immediately, but sometimes the effect of trauma can appear after several hours, like some internal bleeding. So sometime in the initial evaluation, their circulation is fine, but later on they can go in shock. The chest, the abdomen, the pelvis, and the femur and the thigh can accommodate large amount of blood. Also, the problem with breathing and airway can escalate up over time. People who initially appear uninjured may have hidden life-threatening injuries such as internal bleeding. It is very important to reassess trauma patient multiple times, and in particularly anytime patient condition worsen. Anyone in the front line who are supposed to provide care for trauma patients should master the ABCDE approach. This assessment and management should be finished in 5 minutes and repeated as needed. In any patient with confusion or altered mental state, suspect head or spine injury. The first thing to assess is airway. Look, assess, listen. Look for anything that can obstruct the airway, like presence of vomiting or bleeding, swollen tongue, other object obstructing the airway. Look for feature of burning on the face, soot around the nose, and burn nasal hair. And also look for any obvious trauma in the head or neck, and expanding hematoma, swelling, swelling, and also assess for altered mental status and confusion, as this might reflect head and spine injury, and patient with altered mental status might not be able to protect their airway. And then listen for abnormal airway sound indicative of airway obstruction, like gargling, snoring, stridor, or any noisy breathing. After you assess the airway, you need to manage. And whenever we manage patient with trauma, we have to consider spine, cervical spine, stabilization and immobilization. And when we try to open the airway, we use jaw thrust. Avoid head tilt, chin lift, because this will aggravate spinal injury. If there is any vomitus or secretion or blood in the mouth, try to suction that. If there is an obvious foreign body, remove it. If you need to maintain the airway open, you can use oropharyngeal or nasopharyngeal. But when you are suspecting fracture base of the skull, avoid nasopharyngeal. Patients who are conscious, usually they don't tolerate oropharyngeal airway. You have, at this phase, you have to recognize if there is burn on there is airway burn or expanding hematoma, and then you need to assess if you can handle this patient in your facility, or you have to send him somewhere else. During airway assessment, if the patient is conscious and he can speak, this can tell you a lot that airway is open. After you assess and manage the airway, then you go to breathing. The same thing: look, listen, and feel. Look for increased work of breathing. This can signify significant injury. And look for chest wall movement, if the chest wall is moving at all or not, and if it's moving symmetrically or one side moving more than the other. And look for tracheal shift, because this can happen with massive hemothorax and tension pneumothorax. And look for sucking chest wound, and look also for cyanosis. Look for abrasion, bruising, other sign of injury, because this can indicate severe injury and can be associated with lung injury or accumulation of air or fluid in the pleural cavity. And look for circumferential burn to the chest or abdomen, because this can lead to compartment syndrome later on. After you look, then you listen. Absence or decreased breath sound, because this can indicate hemothorax or pneumothorax. Listen for percussion note, hyperresonant. It indicates accumulation of air, that could be tension pneumothorax, and dull percussion note can signify hemothorax. Feel for crepitus, cracking and popping with palpation, because this can be also associated with pneumothorax. Managing breathing, we give oxygen to any hypoxic patient or when there is excessive work of breathing. If there is a tension pneumothorax, we do needle decompression, provide oxygen, IV fluid, and later on you need to place a chest tube. Those with sucking chest tube, this can progress to tension pneumothorax. You have to do three-way dressing. If breathing is not adequate or patient is hypoxic in spite of oxygen therapy, then they might need back valve mask ventilation. Those with chest or abdomen burn, restricting breathing, you need to see if you can handle them in your facility or to transfer them to another for scrotomy, or just call a surgeon if you have them on board. After you assess the airway, manage the airway, assess breathing, manage breathing, then you come to circulation. You would like to demonstrate if there is feature of hypoperfusion and shock. Look for capillary refill if it is more than 3 seconds. Look for pale extremity, which can indicate severe vasoconstriction. Look for distended neck vein, because this can happen with obstructive shock and tension pneumothorax or cardiac tamponade. Look for external and internal bleeding, common site for bleeding. Chest, so you look for hemothorax and abdomen, pelvis, in the thigh, the site of amputation, large external wound, and burn. Look for burns, the size and depths. Feel for cold extremities, which can signify hypoperfusion, and this can be accompanied by altered mental status. Because this also can reflect poor perfusion. And look for weak pulse and tachycardia. For circulation management, when there is an obvious bleeding, apply direct pressure or deep wound packing to control active bleeding. You can apply tourniquet to amputated limb or uncontrolled bleeding, and try to place peripheral line to large pore cannulae. Start IV and plan for surgical assessment. And if ongoing bleeding, in addition to fluid resuscitation, prepare blood. In patient with burn injury, start IV fluid according to the burn size. Limbs, fractured limb should be immobilized. Those with pelvic fracture can use pelvic binder. And if there is a penetrating object, leave it on place. Stabilize the object and get appropriate consultation or transfer to facilities that can handle him. Pregnant lady should be placed on the left side while maintaining spine immobilization. After we stabilize airway, breathing, circulation, we look for disability, look for confusion, lethargy, and agitation. Always consider hypoxia, hypoperfusion as the causes of confusion and agitation. Then consider that it is related to head injury. Look for seizure and convulsion. Look for pupillary size, reaction to light. Look for any deformity in the skull, depressed fracture and cut wound. Look for bleeding or fluid from ear and nose that can signify fracture base of the skull. And check for consciousness and assess the Glasgow Coma Scale or AVPU approach. If the patient is alert, he can respond to verbal stimuli, painful stimuli, or unconscious. And look for movement on the extremities and sensation in all extremities. And don't forget to check blood glucose because hypoglycemia can be there. Disability management, whenever the GCS less than 9 or in AVPU approach, they are responding only to painful stimuli, you need to decide if you will be able to handle this patient in your facility or you need to transfer. And whenever you need help, call for help. Any patient with lethargy, confusion, or unconscious make sure he has adequate oxygenation and consider giving oxygen to this patient, and make sure they have good perfusion. Any patient with altered mental status, after you secure airway and oxygenation and perfusion, consider head injury or spine injury. Don't forget to treat hypoglycemia and give glucose, and in those with convulsion, you consider or give benzodiazepine. Finally, you come to the exposure. Remove all clothing and maintain the dignity of your patient. Examine the entire body for evidence of injury, including back, groin, underarms. Assess the patient back and spine using the log roll maneuver, and we're going to have a link to a video showing you how to do the log roll. Managing exposure. If a spine injury is suspected, perform log roll maneuver to examine the back. Remove any restricting clothing, as the body might swell. Any jewelry or restricting clothing should be removed. If the clothes are wet, remove them to avoid hypothermia, and dry the patient. Cover the patient as soon as possible, and always respect patient modesty and dignity. Remember, whenever you are assessing patient with trauma during primary survey, people who initially appear uninjured may have hidden life-threatening injuries such as internal bleeding. It is very important to reassess trauma patient frequently using the primary survey, and should be repeated frequently. Vital signs should be checked at the end of primary survey, but do not delay intervention for vital sign, and we'll continue in another session.